sliding into home plate during baseball game 30 minutes ago. On arrival, his arm is splintered in a newspaper wrapped with duct tape. He's in acute distress. Exam of the right upper extremity shows edema and severe tenderness around the elbow. There is a distal right humeral deformity. Radial pulses are decreased on the right. X-ray of the right upper extremity shows a transverse fracture of the right distal humerus metaphysis with posterior displacement of the distal fragment. This patient is at greater risk of which of the following sequelae?
Okay, it's brachial artery injury. In acute evaluation of the extremity fracture, in acute evaluation of the extremity fracture, it is important to evaluate for signs of neurovascular compromise distal to the site of the injury. The major the major adjacent to the distal humerus include the ulnar nerve and posteriorly near the medial epicondyle, the brachial artery and the median nerve. In the midline anteriorly, the radial nerve anterior to the radial nerve anterior to the lateral epicondyle. In midline transverse fracture of the distal humerus metaphysis as seen in this patient. In midline transverse fracture of the distal metaphysis as seen in this patient, the brachial artery, the median nerve are the highest risk for compromise. The brachial artery bifurcates into radial and ulnar arteries just distal to the elbow joint. In this patient, a brachial artery injury is the most likely sequelae because of the finding of a decreased radial pulse. If signs of neurovascular compromise are observed, emergent reduction of operative fixation is indicated, followed by a period of 6 to 8 weeks of immobilization to allow for fracture healing. Can you explain this? Like how we can assess that this is brachial artery injury, why it is not ulnar nerve entrapment?
Oh, I think he's saying that the ulnar nerve will be injury on the medial epicondyle, and then the what's the other one? The brachial artery and the median nerve will be injury on the in the midline. So in the midline, and then on the lateral epicondyle will be the radial nerve. So if you look at your elbow, it will be medial. That's which one is it? Medial, that's ulnar. Medial epicondyle, that's ulnar nerve injury. Then if you go to the middle, that's brachial artery and median nerve. And then you go to the lateral, that's radial nerve. And then the other clue, I guess, on the question is here where they say radial pulses are decreased on the right, whatever. I guess that's the clue that they are giving on the question. That is something going on with the blood vessel, not with nerves.
Okay,
Yeah. Can you read C, D, and E?
yes.
Mhm.
Fracture non-union is caused by incomplete bone repair. Incomplete bone repair as operative or non-operative treatment. Risk for non-union include unstable fracture pattern, infection, open fracture, or metabolic or endocrine abnormalities. Because this patient has decreased radial pulse, the most likely sequela is brachial artery injury. Pulse, okay, most likely sequela is brachial artery injury. Okay, growth plate injury can occur when a fracture, growth plate injury can occur when a fracture affects the physis. The physis is found within the metaphysis and the epiphysis in pediatric patients. Injury to growth plate can result in limb length discrepancies. For this patient, imaging studies show a of transverse fracture through the metaphysis which is proximal to the growth plate, making a growth plate injury less likely. An ulnar nerve entrapment can occur with fracture affecting the medial epicondyle. Symptoms of ulnar nerve entrapment include weakness in many or weakness in many of intrinsic hand muscle as well as numbness and tingling of the right finger and small finger because of the location of the fracture. In this patient, the finding of decreased radial pulse brachial artery injury is the most likely sequela of this fracture feature.
Okay.
Okay.
Yeah. Next. 17 girl brought to the physician by her mom because she is concerned that her daughter has never had a menstrual period. The mother reports that her own menarche occurred at 13. The patient has no history of serious illness, doesn't take medication. She's in 11th grade, received good grades, and sings in the school choir. She has never been sexually active. She is 5'8", 145, BMI is fine. Blood pressure is a bit low. Breast development is stage 5, so it gets good. Pubic development is stage 2. Exam of the external genitalia shows no abnormality. Insertion of a speculum into the vagina is difficult. The cervix cannot be visualized or palpated. Uterus is not palpable. Karyotype analysis shows a 46 XY, so she's male. Which of the following is the most appropriate next step in management?
Okay. Androgen insensitivity syndrome. Insensitivity syndrome is caused by defect in the androgen receptor complex resulting in genetically XY male genetically XY male patient developing a female phenotype. Testes are present and produce testosterone normally, but the absence of testes are present, but the absence of functioning androgen receptor prevents hormone binding and thereby prevents development of male sexual characteristics. Patients present with female external genitalia, scant pubic axillary hair, absent uterus, fallopian tube, and rudimentary vagina. Patients demonstrate increased concentration of testosterone, estrogen, and LH means will not occur as a result of lack of cycled progesterone and estrogen and the absence of functional uterus with endometrial lining. The testes of the patients uh, cannot functionally produce sperm. The testes of the patients cannot functionally produce sperm, and patients are at high risk for developing testicular malignancy. For this reason, the next step in the management of this patient is gonadectomy. Okay?
Can you read C and E?
Yes. Hormone therapy may be appropriate intervention in patients with androgen insensitivity syndrome. However, given increased risk of testicular cancer, gonadectomy is appropriate next step in the management. Hormone therapy could be considered in the long-term management of the patient depending on the patient's gender identity and desired anatomical gender presentation. and neovaginostomy may be appropriate intervention. Neovaginostomy may be appropriate intervention in a patient with androgen insensitivity. In a patient with androgen insensitivity syndrome, however, much like hormone therapy, the risk of testicular cancer must be addressed. Gonadectomy is most appropriate next step for this patient. Neovaginostomy may be appropriate intervention for depending on the patient gender and desired anatomical gender presentation.
What is neovaginostomy means?
I don't know. I've heard first time.
To, oh, create neovag-
Neovagina.
oh, create a vagina. Okay. Okay. Surgery to make a vagina. Okay. Next. 1990 woman who lives alone is brought to the ED after her family found her lying on the floor of her home. She did not have loss of consciousness. She has hypertension, diabetes. On her arrival, her pulse is 60, respiration 14, blood pressure 110 over 60. Exam shows an open fracture of the tibia. Okay, antibiotic therapy is given with irrigation, is recommended with irrigation, debridement, and surgical stabilization of the tibia with an intramedullary nail. The patient insists that she will allow irrigation, debridement, and antibiotic, but refuses the surgical stabilization and requests discharge to home as soon as possible. Her family provides documentation that the patient has appointed her son as her durable power of attorney. Which of the following is the most appropriate next step?
Okay. So this patient, like elderly patient, assess the patient's decision making capacity. Elderly or cognitively impaired patients should be assumed to lack decisional capacity regarding their care on the basis of the age or cognitive ability alone. To meet the criteria for decisional capacity, the patient must express a consistent choice, demonstrate an understanding of the risk and benefit of the choice, demonstrate mm, an understanding of the significance of the choice for their personal circumstances, and be able to reason through the options. Therefore, to assess this patient's decisional capacity, the physician should discuss the patient's preference for the care of her fracture and the four assess the four decisional capacity criteria specific to the decision. If she possesses decisional capacity, her wishes should be respected. If she does not possess decisional capacity, then the decision should be deferred to her durable power of attorney. Decisional capacity is specific to each decision, as the physician cannot feasibly assess patient's understand of every decision. Patient's global decision-making capacity is referred as competence and is determined by courts, not physicians. Okay, physicians' global decision-making capacity is referred as a competence and it's determined by the court,
Mm-hmm.
not by the physician.
Mm-hmm.
Like,
There's a. Mhm.
what does the global, like, if I would need to confirm that he wants to do the surgery or not, then
Mhm.
what I need to do? I need to assess the patient or I need to send the patient to the court.
Oh, I think they're trying to say that there is a difference between decision making capacity and competence. Decision making capacity, you assess it as a doctor, but competence is the court. So,
Competence, the last line, what does it mean? The global decision making capacity, what does it means?
oh, it just means that competence is to assess if the patient is mentally okay. in every aspect, like at home, to make decisions, like to open an account at the bank, to whatever. In every aspect is competence, and that's the court that decides that, not you. But
Okay.
you do decision making capacity. That's right now, like if the patient comes to the hospital and she's in this situation, I don't want to receive blood transfusion, you decide if the patient can make this decision or not. So at the moment, you don't decide if he can live by himself at home, if he can take care of his businesses or whatever at home, whatever. You just decide what he's doing right now at the hospital with you. So you get it? Does it
Okay.
make sense?
Yes.
Yeah. Can you read B and E?
Yes. Discuss the situation with the patient's sons would be premature. First, the physician should assess the decisional capacity. If she lacks capacity, then the physician should discuss the situation with the patient's son. Stabilize the fracture with cast immobilization to abide by patient's wishes would be stabilize the fracture with cast immobilization to abide the patient's wishes to be premature. First, the physician should assess the patient's decisional capacity. If she possesses decisional if she possesses decisional capacity, then the physician should abide by her wishes. Okay.
So that's mostly for all people and cognitive impaired people. Okay, 21 man comes to the physician for examination prior to employment. He feels well, he has no history of serious illness and takes some medication. He's in his first year of law school and sleeps 4 to 5 hours nightly. Um, okay. He reports feeling stressed frequently because of the demanding course load. He has smoked 1 pack of cigarettes daily. Okay. For 2 years and drinks 1 beer daily. He is 5 foot tall, 5'10", and weighs 200. So BMI is fine, pulse is fine, blood pressure is pretty high. Examination shows no abnormalities. Um, Serum electrolyte concentrations are fine. Urinalysis is fine. In addition to subsequent BP measurement, which of the following is the most appropriate next step?
Okay. This patient has mildly elevated blood pressure and several risk factors for hypertension that may be consistent with primary hypertension. Importantly, one isolated elevated blood pressure reading is an in an asymptomatic patient. Elevated blood pressure reading in an asymptomatic patient does not indicate the patient has hypertension. These elevated pressure need to be confirmed with both in office or and at home measurement or with serial in office measurement over a period of weeks to months. The primary factor determining blood pressure are renin-angiotensin aldosterone system, sympathetic nervous system, and plasma blood volume. Although the exact pathogenesis of primary hypertension is unclear, there are several risk factors thought to contribute, including advancing age, obesity, sedentary lifestyle, smoking, genetic factor, high sodium diet, excessive alcoholic beverage, mm, excessive alcoholic beverage consumption, insufficient sleep, or left untreated. Hypertension can lead to many detrimental long-term effects, including heart failure, ischemic and hemorrhagic stroke, CKD. If hypertension is confirmed, although testing should be done to evaluate for end organ damage or appropriate treatment, lifestyle modification, antihypertensive agent should be discussed with the primary care provider. Okay,
So what we are not doing the serum aldosterone renin ratio because what? Because
because
mhm.
it is this aldosterone ratio. or other. It is for secondary hypertension. We haven't confirmed the primary hypertension yet, so how will assess the secondary hypertension? Like somebody has high BP for once, like this person has high blood pressure, but it is just single blood pressure measurement, and you don't know the uh, continuous blood pressure measurement, so you cannot start the drug. So now you need to do anything. And
Okay.
aldosterone renin ratio for secondary hypertension, like if it is primary hyperaldosteronism like Conn syndrome, which is the cause of the secondary hypertension, then we need this renin aldosterone ratio, isn't it?
Mhm.
And other hypertension like secondary hypertension, renal CT scan, it is done for renal artery stenosis.
Okay.
So renal artery stenosis, this 21-year-old man is very uncommon.
Okay. Okay. Next. 18 men brought to the ED 25 minutes after being involved in a motor vehicle collision. He was the unrestrained driver. He had shortness of breath and moderate left-sided chest pain. Temperature is fine, pulse is high, respiration high, blood pressure a bit low. Exam of the chest shows numerous abrasion and tenderness on the left. Breath sounds are decreased on the left. Heart sounds are normal. Abdominal exam is fine. Pulse oximetry is 40% of face mask shows 92%. X-ray of the chest shows the left-sided pleural effusion. Which of the following is the next step in management?
Okay, chest pain, shortness of breath, tachypnea after blunt traumatic injury raises concern for rib fracture, pulmonary contusion, pneumothorax, cardiac or pericardial injury, great vessel injury, and hemothorax. Rib fracture can be complicated by injury of adjacent visceral or parietal pleura or blood vessel, allowing air or blood to collect in between the visceral and parietal pleura. Hemothorax results from blood accumulating. Hemothorax results from blood accumulating within the pleural space, often from trauma to the pulmonary bronchial, often from trauma to the pulmonary bronchial or intercostal vessel in the setting of rib fracture, blunt or penetrating trauma. It presents with chest pain, shortness of breath, dullness to percussion, diminished breath sound on the affected side. If massive hemodynamic instability may occur, indicator of massive hemothorax include hemodynamic instability where greater than 1000 to 1500 ml of blood is drained within with initial insertion of the chest tube and if greater than 200 ml per hour of blood drains at 4 hours. Pulmonary injuries are typically treated supportively with oxygen supplementation, pain control, exclude significant um, okay, pulmonary injuries are typically treated supportively with oxygen supplementation, pain control to reduce complication of atelectasis and pneumonia. In the presence of an associated pneumothorax or hemothorax, in the presence of an associated pneumothorax or hemothorax, tube thoracostomy may be necessary. Tube thoracostomy may be necessary to promote lung expansion, exclude significant hemorrhage, and prevent residual pneumothorax empyema, fibrothorax fistula. Short-term complication of hemothorax exclude empyema, atelectasis, superimposed infection, and/or hemorrhagic shock. Given these patients tachycardia, tachypnea, and increasing oxygen requirement, tube thoracostomy is the best next step. Why we are not doing the thoracocentesis?
Yeah, can you read that one?
Yes, thoracocentesis is not a sufficient treatment for this patient at this time. In this case, thoracocentesis would have more diagnostic value than therapeutic value because of presumably rapid accumulation of the blood within the pleural space. Tube thoracostomy is more appropriate to remove the large quantity of the blood and can be left in place to trend and monitor of ongoing bleeding while in the lung.
Okay, so thoracocentesis is to take a little bit and diagnose the cells in it, and I guess thoracostomy is to drain. Okay.
Thoracostomy is the drain, and video assisted thoracoscopy, that one is like surgery.
It is for what?
Video assisted thoracos initial management of in patient with a hemothorax.
Okay.
Immediate intervention with tube thoracostomy is most appropriate if greater than 1115 ml is drained with an initial insertion of the chest tube greater than the patient is defined as having major in this case video assisted thoracostomy okay. If if major like massive amount of blood is drained like more over 1500 or
Mm-hmm.
200 ml per hour at least 4 hours. In that case, video assisted thoracoscopy or thoracotomy would be indicated for assessment of the location of bleeding and to control the established hemostasis. I think that like the next step of tube thoracostomy is the uh, thoracotomy.
Okay. Okay, so it's first chest is we first do chest thoracostomy and after we do thoracotomy or video, whatever. And then if there is you want to do diagnostics of the cells, then you do thoracocentesis. Thora-
Thoracocentesis, like if small pleural effusion or
mhm,
moderate pleural effusion, then you need
mhm,
thoracocentesis.
thoracentesis. Okay, got it. Next.
Yes.
37 woman comes to physician for preoperative exam 2 weeks prior to undergoing a splenectomy. She received the diagnosis of immune thrombocytopenic purpura 3 months ago. Her platelet count ranged from 5,000 to 20,000 for the past 2 weeks, despite treatment with steroids and IV immunoglobulin for 2.5 months. Her only current medication is prednisone. She has smoked one pack of cigarettes for 20 years. Exam shows scattered petechiae and multiple ecchymosis over the upper and lower extremities. This patient should receive which of the following vaccines preoperatively?
Okay.
She,
The, this patient has splenectomy. This patient prior to go the 2 weeks prior to undergoing splenectomy, and in this splenectomy patient we need like capsulate. In a patient with splenectomy, capsulated organism can cause infection, isn't it?
mm-hmm.
So we need to give all the capsulated organism protection, like all the vaccine, like Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitis.
Okay. Next.
Next.
Previously healthy 15-year-old boy brought to the ED because of a 3 hour history of severe abdominal pain, nausea, and vomiting. He was kicked in the abdomen while competing in karate. He initially reported only mind belt, but now rates it at 8 out of 10. Abdominal exam shows diffuse tenderness to palpation that is most severe in the epigastric region. Which of the following is the diagnosis?
Okay. Acute pancreatitis presents with epigastric abdominal pain that radiates to the back, along with nausea and hematemesis, often with often in a patient with a history of gallstone, alcohol use disorder, trauma, hypertriglyceridemia, hypercalcemia. Trauma to the epigastric area can cause acute pancreatitis. Acute pancreatitis can be complicated by necrosis, hemorrhage, abscess. Um, of the formation of the pseudocyst lab show serum amylase lipase is high. Treatment of uncomplicated acute pancreatitis is largely supportive and should include IV fluid, either normal saline or Ringer's lactate, bowel rest, pain control, surgical intervention may be required in case of complication. Okay, why it is not hepatitis? Hepatitis can be caused by viral infection, autoimmune disease, alcohol use, medication, hyperbilirubinemia with jaundice or icterus may be found. It is typically chronic, not acute, and it is not caused by blunt abdominal trauma. So, blunt abdominal trauma cannot injure the liver.
Yeah,
It is isn't like epigastric region. If we palpate the liver, we can find the liver in the epigastric region, isn't it?
no, usually if they want to guide you through the liver, if they want to, they will do the right upper quadrant thing, right upper quadrant pain. Usually, if they want to say something has to do with the liver, usually it's not like epigastric. But it
Okay.
can, you're right, it can be caused by blunt abdominal trauma because I've seen questions that cause that. The spleen and the liver with
Like
blunt
liver
abdominal.
injury can happen uh,
Yeah.
in blunt abdominal trauma,
Yeah.
while fighting or like while doing karate.
Yeah. I
Okay.
mean, not I never seen while fighting, and what I've seen like the person that jumps out of the window or whatever and falls on the floor or whatever. That's the ones I've seen with liver trauma, like jumping from a building or falling from the stair down, whatever. That's the ones. Those are the questions I've seen with liver
Okay.
trauma, not the karate and all that. Can you read C?
Yes. Gastroenteritis is a common and self-limiting illness characterized by nausea, vomiting, diarrhea, and mild generalized abdominal discomfort. It is typically as infectious cause. It is typically as infectious cause, either viral or bacterial. It is not associated with abdominal trauma. This patient has focal epigastric discomfort. This patient has focal epigastric discomfort, focal epigastric abdominal pain, and there is severe, which is consistent with pancreatitis, which is more consistent with pancreatitis.
Okay. What happened? Okay. 37-year-old man comes to the physician for examination required by his employer. He feels well. He has no known allergy, no serious illness, no medication. Smoke for 20 years and drinks 6 beers weekly. He has sedentary life. BMI is, I guess, normal. Pulse is normal. BP normal. Lungs are clear. Prolonged expiration. There is prolonged expiratory phase of the lung. Cardiac exam is fine. During the exam, the patient asks what he can expect if he quits smoking now. Which of the following is the most appropriate physician response?
Okay, it's age-related decline in the pulmonary function. Okay, healthy individuals who do not smoke experience age-related decline in the pulmonary function at around 25 years. At around 25 years, for example, the lung parenchyma typically loses its scaffolding, leading to dilation of air space known as senile emphysema. Alveolar dead space also increases. Smoking increases the rate of age-related decline. Smoking cessation is the most likely intervention to prevent worsening of this patient's obstructive lung disease. Long-term smokers are at risk of numerous diseases of the lung, including COPD, which is diagnosed by spirometry. This patient with a prolonged expiratory phase may have smoking and age-related lung decline and chronic obstructive pulmonary disease. Further diagnostic testing is needed to determine the diagnosis. Other common symptoms include dyspnea on exertion and productive cough. Treatment focuses on preventing decline in respiratory function through smoking cessation, in addition to the use of the medication such as inhaled antimuscarinic, short and long-term beta agonists, and corticosteroid. Patients with resting or ambulatory saturation less than 88% are the candidates for oxygen therapy.
Can you read B and C, those two options? Sorry.
In 5 years, your risk of lung cancer will decrease to that of the non-smoker, and your risk of lung cancer will be the same as now are inaccurate. The patient's lung cancer risk will remain increased compared to the general population because of his smoking history. However, his future risk will decrease if he quits smoking compared to if he continues smoking. Your pulmonary function will not decrease further in the future is inaccurate. Age-related pulmonary function decline typically begins around age 25 years. Dilation of air spaces and increased alveolar space commonly occur with age.
Wait, so they're saying that the risk of lung cancer will still be increased in the future, even if he stops smoking, right? That's what they're saying.
Yes.
Okay. Okay. Next. 38 woman comes to the office for evaluation of several red painless lesions of her chest and abdomen that she first noticed 4 months ago. Medical history is remarkable only for occasional headaches, which she describes as generally right-side and throbbing, with associated nausea or migraines. Ibuprofen partially relieves the pain. She also takes oral OCPs. Her last menstrual period was 3 weeks ago. She is sexually active with one male partner and does not use condoms. She has smoked for 15 years and drinks one beer daily. Vital signs normal physical exam discloses several small 3 to 5 millimeters light raised erythematous lesions on her chest and abdomen. What's the most appropriate diagnostic study?
What is your diagnosis? Just looking at the picture.
I do not know.
Looks like cherry.
Cherry, like cherry angioma.
Yes, you are right.
Okay, cherry angioma.
So this type of question we need to find out just looking at the picture because nothing is written. And angioma, there is no diagnostic study and it is self-limiting. If the hemangioma is bigger, like involving the face, then you can give the beta blocker like propanolol,
Mm-hmm.
and there is no other treatment as far I remember. It is important for cosmetic reasons, so cosmetic surgery may be done. Okay. No diagnostic study are required to diagnose the cherry angioma. Cherry angioma are common benign vascular lesion that may appear in patients after age 30.
Mm-hmm.
Mm, Patients often note an increase in the number of cherry angioma as they age. Clinically, cherry angioma are characteristic small, bright red, dome-shaped papule found on the scalp and extremity. Histological examination of cherry angioma shows congested, dilated capillaries and venules within the superficial dermis. Patients may desire removal of the individual lesions for cosmetic reason or due to irritation. However, in general, no treatment is indicated. Patients who develop these growths should be provided reassurance by the physician. Okay.
Can you read B and C?
B and C.
Mm-hmm.
Okay. Excisional biopsy of a lesion may be required for the diagnosis and treatment of the skin malignancy, including Kaposi sarcoma. Kaposi sarcoma is a vascular malignancy commonly associated with severe immunocompression. Patients who develop Kaposi sarcoma presents with violaceous macule, papule, nodule of the skin. While Kaposi sarcoma represents a vascular malignancy, it is usually associated with immunosuppression it is usually associated with immunosuppression, and individual lesions grow with time, unlike cherry angioma seen in this patient. HIV antibody test may be used in patients where this concern of Bartonella Hansley infection. Bartonella Hansley should be associated with the development of bacillar angiomatosis following a cat scratch bite. Bacillar angiomatosis is common in individuals with advanced HIV. It presents as vascular papule or nodule that enlarge and ulcerate the surrounding by a collarette of scale. Treatment for bacillar angiomatosis include antibiotic therapy such as erythromycin or doxycycline. Unlike cherry angioma, bacillar angiomatosis is associated with cat bite or severe immunosuppression and require treatment with antibiotic therapy. Okay.
Okay. 64 men comes to the office because of a former history of moderate painful ejaculation during sexual intercourse. Occasionally, he says the ejaculate is dark and foul-smelling. He also had low back pain and mild lower pelvic pain for 8 weeks. During the past 6 months, he has been sexually active with 4 women. They use condom inconsistently. He says he has paid for sex and had unprotected anal during this time. The patient's vital signs are normal. Exam shows circumcised penis with no lesions. The testes and epididymis are normal. The prostate is mildly tended to palpation and minimally enlarged. Which of the following is the most appropriate next step in diagnosis?
Okay, it's bacterial prostatitis, chronic bacterial prostatitis. It is with symptoms of recurrent UTI, chronic bacterial prostatitis. With symptoms of recurrent UTI, pelvic or lower abdominal pain, dysuria, or painful ejaculation, obstructive symptoms such as urinary frequency, urgency, or difficulty voiding, and sexual symptoms such as bloody or discolored ejaculate, decreased libido, or erectile dysfunction. In contrast to acute bacterial prostatitis, patients are less likely to present with fever. Patients may be asymptomatic. Recurrent flares of symptoms, the most common risk factor. Recurrent flares of symptoms. The most common risk factor include multiple sexual partner, unprotected anal sex, and the presence of concomitant sexually transmitted infection and the presence of concomitant sexually transmitted infection. The diagnosis is most commonly established with the two glass test in which a urine sample is collected before and after prostatic massage and used for culture and microscopy. A tenfold rise of bacterial concentration following prostatic massage localizes the infection to the prostate and is considered diagnostic. This is helpful to distinguish the prostatic infection from other urinary tract infection such as urethritis, cystitis. Fluoroquinolone antibiotics is the mainstay of the treatment. Although the recurrences are common, curative outcomes are more frequent in antibiotic naive patients, less frequently in patients with prostatic calculi. Okay,
Uric A.
yes. Abdominal ultrasonography is often Abdominal ultrasonography is useful for the evaluation of the pyelonephritis or kidney stone, but is not useful for diagnostic of prostatitis. While pyelonephritis may cause flank pain or or foul-smelling urine, it is typically present with acute symptoms of fever, chill, nausea, or vomiting. The lack of systemic symptoms, and foul-smelling ejaculate rather than urine are more suggestive of prostatic infection.
76 men admitted to the ICU because of 12-hour history of moderate chest pain and progressive shortness of breath. Okay, he has no history of serious illness, doesn't take medication, temperature is fine, pulse is fine, regular, respiration a bit high, blood pressure low, pulse oximetry on oxygen by cannula is 88. Exam shows jugular venous distension and the angle of the jaw bilaterally to the angle of the jaw bilaterally. On pulmonary exam, diffuse crackles are heard bilaterally. Administration of 100% oxygen by face mark is started. His BP decreases even more. Echo shows an ejection fraction of 10%. ECG shows evidence of anterior MI. Administration of which of the following is most likely to improve this patient condition?
So ECG show anterior MI and the patient is in shock. So it is cardiogenic shock. So in cardiogenic shock, we can use dopamine or dobutamine as an inotropic. So this patient with recent anterior MI, hypotension, chest pain, respiratory distress, hypoxia, JVD distension, pulmonary edema is most likely in cardiogenic shock. The first line therapy for cardiogenic shock is inotrope support, dobutamine or dopamine. Dobutamine is primarily beta 1 adrenergic agonist that stimulates ionotropic or chronotropic activity, resulting in increased cardiac contractility, stroke volume, heart rate, cardiac output. It also possesses modest alpha 1 adrenergic agonist activity, resulting in increased peripheral vascular contractility resulting in increased peripheral vascular contractility that is useful to raise mean arterial pressure. Catecholamine, particularly norepinephrine, and may also be used in conjunction with dobutamine. So catecholamine, particularly norepinephrine, may be used in conjunction with dobutamine, while norepinephrine as a monotherapy or in conjunction with dobutamine may be used in the treatment of cardiogenic shock in current practice. Dobutamine remains the most frequently used agent of choice, though often these agents are used in combination. Okay,
Can you read C and E? No. Yeah,
okay,
C and
yes.
E.
Isoproterenol is a non-selective beta agonist. Is a non-selective beta agonist that is primarily used in the treatment of bradycardia. Despite its beta-adrenergic agonistic activity, isoproterenol is harmful in the treatment of cardiogenic shock. Isoproterenol is harmful in the treatment of cardiogenic shock in the setting of acute MI, as seen in this patient. Iso, uh, isoproterenol, isoproterenol is harmful in the treatment of isoproterenol is harmful in the treatment of cardiogenic shock in the setting of sorry iso I, can you give me a minute?
Yeah.
Okay, I'm calling.
Past 2 weeks. Examination shows prominent superficial veins over the anterior left shoulder. Anterior left shoulder. Okay. Her the left upper extremity is edematous. From the shoulder to the hand, there is bluish discoloration of the left forearm and hand. Muscle strength and sensation are fine in all extremities. Which of the following is the most likely cause of the edema?
Okay, this patient with unilateral upper extremity swelling. This patient with unilateral upper extremity swelling has a presentation consistent with DVT, deep vein thrombosis. DVTs are the most DVTs are a common in upper DVT are common in the lower extremity, but development of spontaneous upper extremity DVT is rare. This classically presents with this classically presents with in a healthy young athletic individuals after vigorous upper extremity activity, upper body weight training. It is typically associated with anatomical abnormalities of the thoracic outlet that lead to compression to compression and damage to the axillary and the subclavian vein with repetitive upper extremity use. Patients classically presents with arm, shoulder, or neck pain and arm swelling, therefore may be associated with dilatation of the superficial collateral veins over the upper arm and chest. Arshel sign. Diagnosis is made with Doppler ultrasonography showing non-compressible vessel and the intravascular thrombus is shown. Initial treatment is anticoagulation. Okay.
You read A and pick this one. A.
Arterial occlusion leads to acute limb ischemia. If not treated promptly, may develop compartment syndrome. So arterial occlusion leads to acute limb ischemia. If not treated promptly, may lead to compartment syndrome. Patient may present with acute severe limb pain, paresthesia, pulselessness, poikilothermia, Progression to compartment syndrome when the compartment pressure approaches or exceeds the diastolic pressure and the blood flow becomes impaired. The compartment and any downstream supplied structure can become ischemic. Swelling, not pain, swelling, not pain is the patient's primary presentation. The superficial venous distinction is more consistent with venous occlusion.
Yes. Previously healthy 4-year-old girl brought to the physician because of a 3-day history of nosy breathing, runny nose, cough. Her mother says the patient has had decreased oral intake during the past 4 hours with increasingly severe cold, cough and noisy breathing. She has not had drooling or change in the pitch or intensity of her cry. She does not appear to be cyanotic. Temperature is high, pulse is high, respiration normal, blood pressure is low. She can fully open her mouth. She can fully open her mouth. Uvula is midline and the tonsils are mildly erythematous, symmetric, and moderately enlarged bilaterally. Exam shows intercostal and suprasternal retraction, respiratory stridor, and nasal flaring. There are no crackles or respiratory wheezing. Checks X-ray shows shaggy tracheal air column and peribronchial coughing with no parenchymal densities. There is no cardiomegaly. Her symptoms show improvement after 2 administrations of nebulized or semic epinephrine. That's the key. Always sitting upright. Okay, which of the following is the diagnosis?
Okay. This is bacterial tracheitis. Bacterial tracheitis is a potentially serious respiratory infection of the trachea. Potentially serious respiratory infection of the trachea, commonly caused by Streptococcus pneumoniae, Mucorales influenzae, Staph aureus. A bacterial infection of the trachea leads to inflammation and results in difficulty breathing, cough, hoarseness, hoarseness. Typical clinical presentation includes severe cough and difficulty breathing with rapid respiratory rate and intercostal retraction, stridor, fever. Physical examination will show inspiratory stridor, but generally clear, long sounds. Chest X-ray may show peribronchial coughing and tracheal air column with the irregular border. So peribronchial coughing. And is there in other diagnosis where there is peribronchial coughing?
Yeah,
Yes,
I
I
it's a keyword, but I don't remember for what.
but it is not the bacterial tracheitis.
No, it wasn't. There was another one that had that as a keyword.
Yes, peribronchial coughing. Peribronchial coughing and like bacterial tracheitis, like in tracheomalacia, there is another term called tracheomalacia,
Your Malaysia.
where there is uh, in laryngomalacia there is inspiratory stridor, and in tracheomalacia there is expiratory stridor. But this patient, like bacterial tracheitis, there is inspiratory stridor. Okay.
Mm-hmm.
So chest X-ray may show peribronchial coughing and tracheal air column with irregular borders. Diagnosis of the bacterial tracheitis can be made clinically. I don't know how. Prompt diagnosis is paramount to slow and reverse the course of respiratory compromise. Antibiotic is the treatment of choice for bacterial tracheitis along with corticosteroid. Intubation and mechanical ventilation may be required for severe cases, and patients are often hospitalized for monitoring.
You read D.
Yes. Croup, laryngotracheobronchitis. is an acute is an acute upper respiratory infection. Acute upper respiratory infection, often a viral origin, often viral origin. Presentation includes severe cough, which may produce loud bark sound, difficulty breaking, stridor, and fever. While treatment is supportive, severe cases can be treated with nebulized racemic epinephrine. This patient has no response to separate administrations, making bacterial tracheitis more likely. Did you find the clue of diagnosing this?
Um, no, because I think I misread it because I read there is symptom improvement with nebulized racemi. That's why I took group, but it says no symptom. I think the clue is the
Ne-
shaggy type. The clue is
improvement
the
of two administration,
mhm.
there is no improvement, and improvement
Yeah,
happen in epiglottitis,
improvement. No, it's
isn't
not
it?
yeah, it's not epiglottitis because of the. You see, they say they gave one thing here that says that it's not epiglottitis. They gave a clue here.
Yeah, yes, I found it like mouth, like
Here we read it, but I just don't remember what. Not drooling.
not
It's
drooling. Yes,
uh-huh. So do we know it's not epiglottitis? And then when it says no symptom improvement with racemic epinephrine, then we know it's not croup.
croup. Yes,
Yeah, and then when it's bronchiolitis, it's usually less than 2 years old. The RSV.
yes.
Uh,
R is
mm,
less than 2 years, and it is kind of self-limiting.
yeah, and then peritonsillar abscess. They said that it says that the tonsils are mildly red and symmetric. So it's mild. It's not the peritonsillar abscess. The peritonsillar will be like really bad inflamed, but here it's only mild. So I think the clue here is the shaggy tracheal air
Tracheal.
column.
Okay.
Yeah. Let me see. Peribronchial coughing is seen in. I feel like it's bronchiolitis, but I am not sure. Never mind. But I feel like it's. Oh, it says acute bronchitis, but I don't know why I feel like it's bronchiolitis. Either way, I don't think that's a clue because if it's seen somewhere else too.
Like peribronchial coughing in bordetella pertussis.
Oh, it's seen in Bordetella percussis too.
Yes.
Oh, yeah. I guess that then it's not a clue because it's seen in a bunch of things. Okay. Next. 37 women with cystic fibrosis admitted to the critical care unit because of hemoptysis and pulmonary failure. During the past 4 years, she has been hospitalized 9 times for treatment of pulmonary failure and intestinal obstructions caused by Meconium ileus equivalent. 1 month ago, she was in critical care unit for 2 weeks because of worsening lung function. She repeatedly has refused to be considered for lung transplant. She has a living will that states a wish for no cardiopulmonary resuscitation if she undergoes cardiac arrest while hospitalized. Psychological testing during the past year has
It's
confirmed that.
a respiratory syncytial virus, RSV,
Oh,
viral
it's the one that has.
bronchiolitis. You are right.
So it's the one that has peribronchial coughing, right?
Yes.
Yeah, I know. They were.
Yeah, respiratory syncytial virus, like in viral bronchiolitis, there is peribronchial coughing and there is increased interstitial marking. Yes, you are right. It's bronchiolitis.
Yeah, so it cannot be really a clue here, but yeah, I think the clue is the shagged trachea thing.
But we haven't read about the bacterial tracheitis. There is
No,
nowhere. There is
no,
no question in the world as far I know.
definitely not in new word, but maybe. Yeah, I haven't. I don't think in. check inner circle. I don't think so too.
Okay,
Bacterial tracheitis. Nope, no, there is
so
not.
it's a new, like new addition.
Okay. Yeah, the woman with cystic fibrosis admitted to the ICU because of hemoptysis and pulmonary failure. During the past 4 years, she has been hospitalized 9 times for pulmonary failure and interstitial obstructions. Oh, sorry, intestinal obstructions. 1 month ago, she was in critical care unit for 2 weeks because of worsening lung function. She repeatedly has refused to be considered for lung transplant. She has a living will that states a wish for no cardiopulmonary resuscitation if she undergoes cardiac arrest while hospitalized. Psychological testing during the past year has confirmed that she's competent. You see, this is the competent for the for the court instead of the mental capacity thing. This is competent. She is heavily sedated, intubated, and mechanically ventilated. Her pulmonary failure worsens, and her family asks whether extracorporeal membrane oxygenated treatment could be used to improve her condition. Which of the following is the most appropriate uh, physician response?
Okay, this is ECMO is unlikely to change the patient outcome. Do you know vast about the ECMO?
If I know what?
Like, do you know about the detail of the ECMO?
No.
Okay,
So,
I don't know either.
oh, yeah.
That's why I asked. Okay, cystic fibrosis is an autosomal dominant. Cystic fibrosis is an autosomal recessive disorder caused by defect in the CFTR gene, which leads to deficiency of the chloride channel that secretes chloride in the lungs, and gastrointestinal tract reabsorbs chloride in the sweat gland. The abnormal chloride transport causes decreased chloride and water secretion and increased water reabsorption and abnormally viscous mucus in the lung and gastrointestinal tract. Extracorporeal membrane oxygen, like ECMO treatment, involves prolonged mechanical cardiopulmonary support by circulating blood outside the body and subjecting it to gas exchange until respiratory and hemodynamic parameters are met. ECMO is typically used for acute and reversible cause of cardiac and respiratory failure. Contraindication include conditions interfering with recovery, poor prognosis from the primary condition, and is uncontrollable bleeding and is uncontrollable bleeding. Cystic fibrosis is a chronic progressive disorder. Increasing respiratory dysfunction is a common cause of death. While ECMO provides respiratory support temporarily, it is not reasonable to continue indefinitely once a cystic fibrosis lungs have to ceased to function. Some cystic fibrosis use ECMO to temporarily bridge them to lung transplant. However, this patient is not considering for lung transplant. Sorry, ECMO, like it is the bridge for, like if the patient wants to do the lung transplant, then we can offer ECMO for temporary support of the patient for cardiopulmonary support.
Okay. Can you read A and E?
Yes, ECMO is considered because the patient's history of hemoptysis and ECMO is contraindicated because this patient history of hemoptysis is incorrect, though controllable bleeding is a relative contraindication. Though controllable Uncontrollable bleeding is a relative contraindication, hemoptysis is not. If this patient has acute respiratory failure that involved hemoptysis, she would still be a candidate of ECMO. Mm, and this patient will these patients will prevent the use of ECMO is inaccurate. These patients are living well address cardiopulmonary resuscitation but not ECMO. The physician therefore defer decision making to patient's legal next of kin.
Okay, this is ECMO. It's a life-threatening support that temporarily takes over the functions of the heart and lungs, allowing them to rest and heal the heart and lungs. So it involves pumping blood out of the body, passing it through a machine that adds oxygen and removes CO2, and then returning that oxygenated blood to the body. So it like takes over. So it basically does the job of the heart and lungs.
Heart,
Just
it's like temporary
yeah,
heart lung machine.
machine. You see, it takes the blood out. It goes to some. I guess this is the machine, and then it brings the blood back. Yeah, kind of. Yeah. Okay. Next. 42 men comes to the physician because of a 3-month history. Sorry, it's woman. A 3-month history of fatigue, decreased appetite, and mass swelling of her arms and legs. 20 years ago, she underwent transplantation of donor kidney from her sister for treatment of polycystic kidney disease. She has been combined with her immunosuppressive medication therapy. Medications include prednisone and azathioprine. Temperature is fine, pulse is fine, respiration high, BP is high. Exam shows pallor. Abdominal exam shows no tenderness or enlargement of the transplanted kidney. Hemoglobin is low. Serum urea is high. Creatinine is high too. Which of the following is the most likely mechanism of this patient impending renal failure?
Okay, it's chronic progressive transplant dysfunction. Manifest as chronic progressive, chronic transplant nephropathy in the transplanted kidney, chronic rejection which occurs over months to years following transplantation is secondary to a CD4 T lymphocyte response against the donor peptides such as major histocompatibility complex. Resulting T lymphocyte activation leads to cytokine production and both humoral and cellular hypersensitivity reaction. Humoral and cellular hypersensitivity reaction type 2 and 4 respectively. These reactions these reaction results in vascular arteriosclerosis and smooth muscle proliferation with subsequent parenchymal fibrosis and atrophy of the transplanted organ. Diagnostic workup includes serum and urine lab evaluation of kidney function as well as kidney ultrasonography and biopsy, which may show the findings described. Other examples of chronic transplant rejection include vanishing bile duct syndrome of the liver, bronchiolitis obliterans of the lung, and rapid atherosclerosis of the heart. Immunosuppressive medical therapy does not adequately prevent chronic rejection. It is associated with increased morbidity and mortality. Secondary to organ failure, it may require reinitiating kidney replacement, dialysis, or another organ transplant.
Can you read D?
Yes. D.
D.
Hypertension. B.
Mm-hmm. D as in dog.
Hypertension is a leading cause of CKD in the general population, while presentation often includes edema and increased serum creatinine concentration, as in this patient. Onset is usually over the course of years. Chronic transplant nephropathy is more likely in this patient with a kidney transplant and a 3-month onset of symptoms.
Next. Previously healthy 27 men comes to the physician because of nausea, vomiting for the past 36 hours. Temperature is high. Examination shows clear icterus and jaundice. There is tenderness to palpation of the right upper quadrant abdomen. Hemoglobin is, I want to say normal. Leukocyte count is low. Serum bilirubin, total bilirubin is high. Indirect bilirubin is higher. AST and LFT are super high. Which of the following is the most likely diagnosis? And hemoglobin is actually normal.
Like there are two things. If ASTLT, this is my observation, not always correct.
Mm-hmm.
If ASTLT is more than 1000,
Mm-hmm.
there is two differential, either hepatitis A, viral hepatitis, mostly hepatitis A, and second is dengue virus.
Dengue virus. Oh.
Dengue virus, there are other features of the dengue virus like hepatosplenomegaly. You will find hepatosplenomegaly. You will find dengue is called the breakbone fever. There is fever. There is rash. Lots of things present.
Mm-hmm. Mm-hmm.
And in dengue fever, there is like ASTLT is more than 1000. Okay,
Got it.
so this patient who presents with findings of jaundice, direct and indirect hyperbilirubinemia, direct and indirect hyperbilirubinemia, and increase serum liver enzyme, and increased serum liver enzyme, most likely viral hepatitis. Causes of acute hepatitis. Causes of acute hepatitis include viral infection, alcohol, medications, autoimmune disease, ischemic injury, among others. Common symptoms during acute hepatitis can include fatigue, nausea, vomiting, right upper quadrant pain, jaundice, pleuritis, and abdominal distension. Serologic testing for acute viral hepatitis includes anti-hepatitis A virus, immunoglobulin M, and immunoglobulin G antibody, and anti-hepatitis C virus IgM or IgG antibodies, and more specific evaluation. Multiple anti-hepatitis B antibodies and antigens due to propensity of hepatitis B to cause and subacute infection. Other viruses commonly implicated in case of viral hepatitis include herpes simplex virus 1 and 2, cytomegalovirus, Epstein-Barr virus, varicella zoster virus. Management of acute hepatitis includes supportive care and treatment of complications that may arise, such as metabolic abnormalities and hepatic encephalopathy. More specific treatment can be pursued once the underlying cause has been identified. This patient's acute increase in liver enzyme in the absence of leukocytosis indicates viral hepatitis.
You read
In
A and C.
increase liver enzyme in the absence of leukocytosis. In the absence of leukocytosis. Okay.
A and C.
Cholangitis, infection of the bile duct system caused by bacteria in the setting of biliary obstruction. The common presentation of cholangitis include fever, jaundice, and abdominal pain referred as Charcot triad. Charcot triad lab studies will often show increased leukocytosis, increased ALP and gamma glutamyl transferase, and bilirubin In this case, viral hepatitis is more likely due to a leukocyte count with normal limits, the leukocyte counts within the normal limits, and a large increase in ALT or AST. Transaminase abnormalities may exist in cholangitis but would often to be a lesser degree that than seen in the hepatitis. Additionally, the pattern of the bilirubin would the pattern of the bilirubin would more often be cholestatic with a greater proportion of direct hypobilirubemia, though there is marked variability in the presentation.
I
And
see.
C. Choledochal cyst is a congenital abnormality of the biliary duct system. Patient often present prior to age 10 years, but the presentation can occur in adulthood. The most common symptoms experienced include abdominal pain, jaundice, palpable mass, nausea, vomiting. Lab studies usually show liver enzyme within the normal limit as the biliary duct system is generally obstructed. Acute viral hepatitis is more common in the case due to the age of the patient as well as increased ALT and AST identified on liver studies. Okay.
Yes, 9-year-old girl brought to the physician for follow-up exam. She has a 5-month history of intermittent moderate right flank pain that adheres to the back. 5 months. The pain occurs 2 to 3 times monthly and lasts like 2 to 3 days before resolving spontaneously. She has not had fever, vomiting, diarrhea, pain with urination or urinary frequency. She has no history of serious illness, no medication. Multiple urine culture during the past 5 months have been negative. Vital signs normal, abdomen normal. There is right costovertebral angle tenderness. Labs serum creatinine is high. Urine pH is normal. Blood trace blood protein none. The white blood cell no nitrates none. Abdominal ultrasound shows absence of the left kidney and severe dilation of the right renal pelvis. Absence of the left kidney. Which of the following is the most appropriate next step to prevent progression of this patient renal failure?
Okay. So congenital urinary tract abnormalities include but are not limited to unilateral kidney agenesis, absence of one kidney, fused kidney, ureteral stricture and stenosis, duplex collecting system, posterior urethral valves, bladder agenesis, bladder exstrophy, hypo or epispadias, and urethral stricture. In case of unilateral kidney agenesis, care must be taken to preserve the function of other single remaining kidney. Regardless of malformation, ureteral obstruction, VUR are the common complication. Chronic reflux causes hydronephrosis with compression of the atrophy. With compression atrophy, reflux nephropathy of the renal band as shown in this patient's history and ultrasonogram finding. This can lead to kidney failure. Insertion of percutaneous nephrostomy tube to helpful as a temporary measure to prevent progression of the renal failure. Definitive management of the VUR. Prior to definitive management of the VUR or ureteral obstruction. What is the definitive management? And
Hmm, don't know. Oh,
do you know how to give this nephrostomy tube?
no. Is it like it's called percutaneous nephrostomy tube? That's why it's called
Yes,
prostate.
they are telling that this is marketness.
Yeah, is this.
So,
Uh, so yeah, I guess a tube that you put in the kidney to drain the pee. I guess it doesn't go through the ureter; it goes straight to the tube.
like like a bladder, or like putting a bag in the kidney, like
Yeah,
what uh, like Foley's catheter given on the
kidney.
urethra, and this is giving in the
Mm.
in the kidney.
In the kidney, you see, it's like yeah, that's I guess that would be the ureter that comes in, and that would be the bladder. So it drains the pee from the tube to the bag. See,
Okay, got it.
can you read A and D? Like this one and this one.
Yes, administration of the IV intravenous furosemide. Administration of intravenous furosemide and loop diuretics would result in increased urine production. It is mainly used for management of hypervolemia, such as in heart failure or cirrhosis. And there is no indication that this patient is hypervolemic. Given evidence of given evidence of given evidence of existing kidney outflow obstruction, increasing urine output could worsen the post-kidney azotemia. Post-kidney azotemia. A and which one?
C.
Okay, inserting a urinary catheter would be helpful if the location of urinary obstruction is distal, such as with a urethral structure or prostatic hypertrophy in male patient. This patient results in incomplete bladder emptying and increased bladder volume. Patients typically have history of overflow incontinence or inability to void, and a palpable suprapubic mass is disclosed on physical examination. This patient does not have bladder outlet obstruction with a stricture or contracture and would neither benefit from urinary catheter nor from the cystoscopy with bladder outlet obstruction. This patient's obstruction is proximal, leading to hydronephrosis. This requires a nephrostomy tube, not a urinary catheter or urethral dilation. Okay,
21 man comes to the office for routine exam. He was diagnosed with type 2 diabetes 2 years ago. Most recent A1C 1 month ago was 9. His medication are metformin and glipizide. He said he does not check his blood glucose concentration regularly because I just want to be like everybody else. His BMI is fine. Vital signs normal. Exam shows no there are normality. In addition to expressing empathy, which of the following is the most appropriate physician approach to encourage better management of this patient condition?
okay. Organize multidisciplinary medical care. Non-adherence can be difficult situation to face a situation to face as a physician, particularly because each patient is different and their reasons for non-adherence will vary widely. Common reasons are financial strain, cannot afford the medication or treatment side effect, nausea, vomiting, sexual dysfunction, lack of health literacy resulting in a misunderstanding of the disease and treatment plan, social perception or judgment, or in this case, mental and emotional strain. Because of this, taking an open-ended, curious, and non-judgmental approach to figuring out why the patient is non-adherent with a treatment plan is crucial. Employing a plan with without discovering the root cause will likely result in continued non-adherence. In the case of this patient who admits that he does not check his blood glucose regularly and has poor glucose control because he wants to be like everyone else. Addressing his concern from a multidisciplinary approach and connecting him with young patients with similar conditions will be crucial to improve his perception of disease.
Okay, next. 62 man comes to the physician because of a 4 week history of tingling in his left hand radiating to the ring and small fingers. Okay. He has not had any recent trauma or weakness in his hand. Um, he has end-stage renal disease secondary to hypertension. He has been receiving hemodialysis for 3 months. He also has coronary artery disease, type 2 diabetes, congenital heart failure, gout. Current medication, metoprolol, lisinopril, clonidine, insulin, allopurinol, and aspirin. Temperature is fine, pulse is fine, BP is high, lungs are clear. 2 out of 6 systolic murmur is heard at the left sternal borders. There is a dialysis fistula in place in the left upper arm. There is no inflammation, but the thread is palpated. Physical exam shows no edema of the upper or lower extremity. Neurologic exam shows decreased sensation to light touch over the medial aspect of the left hand, ring and small fingers, and the medial aspect of the left arm and the elbow. Okay. Which of the following is the most likely diagnosis?
What if decreased sensation over the ring and little finger? What is your diagnosis? Which nerve is involved?
Ulnar nerve.
So it's ulnar nerve compression. So peripheral nerve particularly. Is there any another clue of this ulnar nerve compression?
Mm-mm. Mm-mm.
Okay. Mm, okay. Peripheral nerve particularly in patients, oh sorry, peripheral nerve particularly in areas that are not protected by the surrounding soft tissue are vulnerable to injury or compression. The ulnar nerve is vulnerable to compression at the elbow or less commonly. Ulnar nerve is vulnerable to compression at the elbow, less commonly the wrist. Common cause of ulnar nerve compression is elbow trauma or compression or traction of leaning on the elbow or repetitive elbow flexion or elbow joint pathology like osteophytes. Patients with AV fistula placed at the elbow commonly experience ulnar nerve compression. Patients typically present with numbness and paresthesia in the ring and small fingers. Patients with ulnar nerve compression at the wrist may also present with hand weakness and atrophy. Electrodiagnostic testing confirm the diagnosis. Treatment typically starts with the behavioral modification and ergonomic improvements. Decompressive surgery is indicated for severe or refractory cases.
Okay. Next. 37 premigravida woman at 18 weeks gestation comes to physician for follow-up. Yesterday her BP was high, 150 over 100. She also has a 10-day history of daily headache, moderate daily headache. She has not had any changes in vision. She has no history of serious illness. Only medication is prenatal vitamin. She's not in distress. She is 5 foot tall. She weighs like 190 pounds. Prior to pregnancy, BMI is 33. She had like 10-pound weight gain during her pregnancy. I guess not bad. Today her BP is even higher, 150 over 98. Well, yeah, it's still high the same. On exam, the uterus is fine and consistent in size with 18 weeks. Fetal heart rate is fine, 155. Urinalysis shows trace protein. Which of the following is the most likely diagnosis?
Okay, it is essential hypertension because according to the uh, definition of the preeclampsia, preeclampsia
Mhm,
is defined as BP 140 over 90 after 20 weeks of pregnancy with proteinuria with or without organ damage, like in preeclampsia. But
mhm,
in gestational hypertension, the BP would be 140 over 90 after 20 weeks, but like in preeclampsia, there is absence of proteinuria or organ damage. If we want to distinguish it from preeclampsia, the gestational hypertension. Got
mhm,
my point? And
mhm,
hypertension before 20 weeks, that is essential or pre-existing hypertension. And there may
mhm,
be presence of protein or may not be present of protein. Protein may be present due to hypertension. Okay.
mhm. Okay,
Yes.
next.
Next. Yes.
42 men with hypertension and end-stage renal disease secondary to autosomal ADPKD comes to the office for routine exam. He feels well. 6 months ago, he received a kidney transplant from his brother. The medications are tacrolimus, mycophenolate. Oh my goodness, what is happening? Mycophenolate, TMPSMX, amlodipine, calicalciferol, multivitamin. Exam shows functioning AV fistula in the left forearm and firm non-tender renal allograft in the right lower quadrant of the abdomen. Okay. Hemoglobin is, I guess, fine. Serum calcium is, let me double check. I feel like this is high. Is high. Urea is high. Creatinine is high. PTH is high. Which of the following is the most likely diagnosis?
It's okay. So it is parathyroid hyperplasia. So in tertiary hyperparathyroidism, PTH is high, calcium is high, and everything is high. Sorry, tertiary hyperparathyroidism is a condition that occurs as a complication of long-term secondary hyperparathyroidism. This often presents with CKD, chronic renal failure, chronic kidney failure. It is characterized by persistent hypercalcemia and parathyroid hormone secretion despite the presence of normal or increased calcium concentration. Normal or increased calcium concentration as seen in this patient. Severe hyperparathyroidism causes parathyroid hyperplasia. The most likely diagnosis for this patient and autonomous PTH secretion over time. These changes lead to development of resistance of PTH, resulting in a failure of negative feedback mechanism that regulates the PTH secretion. Symptoms of hyperparathyroidism may include fever, muscle weakness, bone pain, kidney stone. Treatment usually involves an operation to remove one or more hyperplastic parathyroid glands.
Next. 42 men brought to the ED because of a 2-day history of shortness of breath and cough, which has progressed to severe respiratory distress. He has a history of IV drug use. He lives in a homeless shelter. On arrival, he's intubated and mechanically ventilated. Examination shows coarse breath sounds bilaterally. Coarse breath sounds. Okay. Respiration therapies began. 2 days later, culture of blood and sputum grows Neisseria meningitidis. Which of the following is the most appropriate measure to prevent the spread of this patient disease to hospital personnel? To prevent the spread, okay, of Nigeria. Okay. Nigeria.
Okay. So bacterial meningitis, prophylaxis for close contact only. So bacterial meningitis, sorry,
No, they didn't say anything.
bacterial meningitis presents with fever, headache, nuchal rigidity, and altered mental status, typically following a prodrome of upper respiratory tract infection symptoms. Neisseria meningitis is the most common. Neisseria meningitis is the most common pathogens to cause meningitis in adult. A risk factor of Neisseria meningitis is also called meningococcal disease in a communal living homeless shelters. Empiric treatment involves third generation cephalosporin. Third generation cephalosporin management should also include chemoprophylaxis to the close contact. Chemoprophylaxis is rifampin rifle, isn't it?
Mm-hmm.
Or the triax, ceftriaxone maybe,
Mm-hmm.
according to
Mm-hmm.
a sketchy.
Mm-hmm.
Okay. Close contact are typically defined as individuals who have been close proximity or within feet of the patient for a prolonged time for more than 8 hours, and who have been directly exposed to the patient's oral secretion. Prophylactic is rifampin, ciprofloxacin, and ceftriaxone. Okay.
Okay. Next. 57 men comes to the ED 2 hours after the onset of severe shortness of breath.
What can you tell me the name of the organism which caused the pharyngitis?
What if like pharyngitis?
Yes.
Like sore throat?
Yes, sore throat. Yes.
Is it strep pneumo?
No,
No,
no, no.
wait. Pyogenes.
Group A Streptococcus pyogenes, and then name a virus.
Virus that cause pharyngitis. Hmm.
Adenovirus.
Adenovirus. Oh, yeah, 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 yeah. The red, the
The
red.
den cavity.
Yeah, the then. Uh-huh.
And I ask it for another reason.
What?
Like, what can I say? The Ni- Neisseria meningitis.
Mm-hmm.
The Neisseria meningitis can cause the pharyngitis as well.
Oh,
This is unique.
yeah.
There is one question in the world where I found that Neisseria meningitis can cause the uh,
Pharyngitis.
pharyngitis. Yes.
Hmm. Oh, didn't know that. Didn't see
Okay.
that part. Hmm. 57 men comes to the ED 2 hours after onset of severe shortness of breath. He has not had any other symptoms. He has long-standing hypertension and type 2 diabetes. Current medication is lisinopril, metformin, thiazide. Never smoked. He's employed as a truck driver. His temperature is fine. Pulse is high. Respiration high. Blood pressure normal. Pulse oximetry or room air shows oxygen saturation of 88. Faint wheezes are heard on the left. S4, there is a S4. Exam of the lower extremity shows 1 plus edema bilateral. ECG shows sinus tachycardia. Arterial blood gas pH is, I want to say normal, but let me double check. Where is the pH? Did I pass it? Right here. pH normal. PCO2 is normal. PO2 is low. A chest X-ray is shown. Which of the following is the most appropriate next step in management? I don't see anything on the chest X-ray.
Okay, this is these patients' presentation and finding are consistent with pulmonary embolism. Pulmonary embolism. Acute pulmonary embolism classically presents with acute chest pain, shortness of breath, hypoxemia. Some patients may also experience unexplained syncope. The classic presentation in acute pulmonary embolism is infrequently present. Often difficult to distinguish pulmonary. It is often difficult to distinguish PE from other acute respiratory, cardiac, and systemic disorders on a clinical basis. The differential includes, but is not limited to the pneumonia. The differential includes, but it is not limited to the pneumonia, lung infection, asthma exacerbation, pulmonary hypertension, pericardial tamponade, acute coronary syndrome, panic episodes. The most panic episodes, the many causes of syncope if present, the physician must maintain the physician must maintain a high index of suspicion, and they use clinical decision aids such as well score is recommended. Risk factors for acute PE include immobility, truck driving in the case of this patient,